Well, thank you, Don. I really appreciate it. Hey, Rob. Hey, Maria. Rob.
Hey, Frank.
Great to
Hi,
see you.
Frank. Hi, Rob.
You know, this will be a really interesting conversation. I think one that goes into some places that a lot of people don't often go. Now, I understand that Verily and Colgate are conducting research together to gather more data on the relationship between oral health and overall health. And we'll be talking a lot about that, of course. But before we get to the research, I want to talk for a moment about the misrepresentations and misperceptions about dental care and oral health, misinformation, which is a real problem these days. Now, my hunch is that most people perceive dental care as kind of a mix of, like, I got to go, it's my annual checkup, it's cosmetic, it's cavities, it's wisdom teeth. There are other issues, of course. But can I just ask you both, Maria, do you think there's a lot of misunderstanding about what dental care is and its connection with broader health issues?
Yeah, I do, Frank. And it's interesting, you know, you mentioned the aesthetic part of it, cosmetics. People are very familiar with that. If they get a cavity or they have pain, they know they have to address that. Or if their wisdom tooth has to come out, everyone knows that that's something that needs to be addressed. But I'm actually a periodontist, so I take care of the gums and periodontal disease. And it's not quite as sexy as all the rest of the things that you mentioned in dentistry, but it is the most common chronic inflammatory disease in the world. And most people aren't even aware if they have it because it doesn't often cause pain or discomfort. And it has few signs and symptoms. You know, teeth may, when you brush your teeth, it might bleed a little bit, or someone might note some spaces between their teeth. But for a lot of people, if it doesn't hurt or if it doesn't need to be whitened, they just don't really pay much attention to it. And you know, as you know, inflammation and infection is something that really does need to be managed and treated.
Yeah.
So I think there is a misperception that, you know, it's almost like your head is not connected to your body. And people think that this infection and inflammation that may happen in their mouth really won't have an impact on the rest of the body. And in fact, it does.
Rob, you know, it kind of makes me think of when I go to the dentist, and the dentist always does the lecture on, are you flossing, you know, and there's a reason for that, right? It connects to exactly what Maria was saying, much bigger issues. But you think the misperception problem is a big one?
Oh, I mean, just speaking for the way I see it, it's a huge issue. And, you know, remember that the leading cause of death in the world is still good old cardiovascular disease, something that we sort of in public think we have already taken care of this, we understand it. And even during the COVID pandemic, the number of heart disease deaths in the U.S. were larger than the number of COVID deaths. And this link to inflammation, I think it's now a matter of common public perception that inflammation is associated with blocked up arteries and heart disease, but people haven't associated with the gums. And this periodontal disease, when we look at the mouth, I won't go into details. Maria may want to do this, but when I first learned about just the surface area of the gums and the bacterial content that's in that surface area, it's a little overwhelming actually to even think about it. So I think there's a big public misperception. We need to close that gap, but we also have a lot of evidence that's needed to know what to do about it.
We'll touch on a lot of this in the conversation. I should say, by the way, as we know, and it's in the news these days, Medicare does not cover dental care. There is a pilot dental coverage program that's included as part of this reconciliation bill that may or may not go anywhere. But I'll come back to that. Maria, you're one of the world's top dental researchers, and congratulations on that. It's amazing. Why doesn't oral health get more credit for what it means to be healthy and the kind of doorway to broader health issues and threats?
Yeah, I think Rob, you know, really touched upon something very important. We know, at least in the U.S., at least half of American adults have some form of periodontal disease. And if you think about the surface area of the teeth, it could be equivalent to the surface area of the palm of your hand. And what I say to my patients is, if you had an infection, red and bleeding hand with pus pouring out of it, would you do something about it? And they say, absolutely. But because they can't see it and it's in their oral cavity and only the dentist can actually diagnose this, or the hygienist, by using a probe and looking for pocket depths, looking for bleeding, taking x-rays or radiographs of the teeth to show the bone loss. People just don't look at it the same way.
Maria,
but when you explain it to them, they go, "Oh my God, I would take care of that immediately." So
can I just stop you there? Can I just stop you there? You said half of American adults have some kind of dental gum infection?
Gum disease, yes.
Gum disease? Half?
Yes, half.
That's a huge number. Is that skewed mostly towards older people? Could you just explain a little bit more? That's an incredible number.
55 and older. We know from our public health surveys in the U.S. that half of Americans that age have some form of gum disease, periodontal disease. And we know that if you look at 65 and older, 25% of people become edentulous. They lose their teeth because of gum disease and other oral diseases, which is years and years of infection and inflammation that was not treated. And that's why they end up losing their teeth. And so as Rob said, we know that inflammation, which drives up high sensitivity C-reactive protein, which can be measured in the blood, which is a sign of inflammation throughout the body, that goes up when you have periodontal disease. And that has been associated with risk for cardiovascular disease. It may be even a stronger indicator than lipids. We always look at our cholesterol and lipid levels, but inflammation in and of itself is a very good indicator of someone who's at risk for cardiovascular disease.
Rob, I understand that that you're looking for links between oral health and other health threats. That's part of the project that Verily is initiated. Could you give us a little bit of an explanation, some of the basics on that?
Well, this is part of a much larger project called Project Baseline, which really, I think if you talk to most medical researchers, it's been a quest forever to figure out how all the different parts of the body are related to each other. And until recently, we just haven't had the computing power to look at all these things at the same time. So Verily, as part of the Alphabet family, which includes Google, has access to tremendous computing power and the ability to measure a lot of things about the body all at once. And the analogy I use, which people seem to relate to pretty well, is imagine yourself 20 years ago trying to drive from Connecticut to Colorado. I understand, Frank, you've been in both places and have ties there. You would have had to get a whole set of maps, put them in your glove compartment, stop and ask directions multiple times. Now you just get in your car and start talking to it because all of the roads in the world have been mapped and there's artificial intelligence used 24/7 as things happen on the roads like potholes or crashes or road construction. You know about it instantaneously and it supports your decisions. It doesn't tell you where to go. It gives you options. And it also learns about you, what your preferences are. For biomedicine and healthcare, we have no map. We have a lot of interesting studies, one off, one not related to the other. So Project Baseline is about how to tie all this together for the whole human being and the relationships that we have with each other. A part that we had left out because we didn't know what to do when we designed the project was oral health. And if you think about it, what an amazing opportunity. We got a set of teeth, we have gums. Dentists are really good at examining those. And, you mentioned Medicare. Of course, the dental records are not typically connected to the other health records because the dentist is seen as a separate activity, which doesn't make a lot of sense based on everything we said. So, and I also mentioned, this is something that's not new for me. 20 years ago, we started working between Duke and UNC, believe it or not. That's a rare thing. But UNC has a great dental school, and we were working together to try to do a big NIH project on this. I'm sort of glad it's not happening till now because computing has changed so much. Our ability to measure is going to be so much better.
So, Rob and Maria, let me draw you both into this because you're talking about the computing power that you've got, the ability to do research and take science to new places. You're also talking about this sort of seething cauldron of bacteria and infection and disease. It's our mouths. It's sort of disgusting. Most people think of they brush their teeth or, so their breath is fresh. But Rob, what you're saying is this should be seen as a very big part of our overall health, and it should be monitored in that way. Could you both talk a bit about the connection between oral health and our overall health, and sort of the portal to disease that our oral health can inform. Maria, you want to go first with that?
Yeah, I mean, I agree with you, Frank. This has really far-reaching clinical and public health implications. We know that if you leave periodontal disease untreated, the bacteria around the teeth can actually get into the bloodstream. And they can be found in atherosclerotic plaques, which, are responsible for heart attacks, for stroke, etc. And we know that the risk for heart attacks and stroke go up 2 to 3-fold in people with periodontal disease. We also know that chronic inflammation, as well as the bacterial infection, drives insulin resistance. So Demmer and his colleagues at Columbia followed people with periodontal disease for 20 years, and they were twice as likely to develop type 2 diabetes. So we see these connections, and that's why in the Verily study, we are looking at the oral condition of people with diabetes and or cardiovascular disease. So we'll be able to see if these people that Rob and the team have been following for a couple of years now actually have periodontal disease. And then we'll be looking at what happens if we manage it. If we provide intensive periodontal therapy, can we reduce the risk of a future heart attack by driving down HSCRP levels, by improving on endothelial cell function? Can we improve on diabetes control by reducing A1C levels? And from the UK PDS study, we know that if you reduce A1C by 1%, you get about a 14% reduction in the risk of macrovascular disease. And what kills most people with diabetes is heart attacks. My dad was diabetic, so that's why I studied diabetes throughout my career, is because I have a family full of people with type 2 diabetes. So we'll be able to look at this in our joint study with UNC.
Rob, before I come over to you, Maria, just to follow up though, these are all really important and incredibly intriguing things. But what do we know now about correlation versus causation with some of these things?
Rob, you want me to take it, or you?
Oh, you go first. Frank was referring to you first.
I think that, well-controlled intervention studies will really help us to provide the strongest evidence for the role of periodontal disease as a true risk factor, which is causally linked to important systemic health outcomes. And so this study will look not only at the correlation, right? So we'll be looking to see these people who have diabetes and cardiovascular disease, do they have periodontal disease? And the correlation has been reported many, many times within the literature. So there's a lot of data looking at that. The causation piece really comes from those well-controlled studies where we manage periodontal disease. Now, one of the things that is an issue here is there are many, many common risk factors for periodontal disease and cardiovascular disease. To give an example, smoking is a common risk factor, right? But despite that, when we eliminate those common risk factors and then you manage the periodontal disease, you can see differences. And this has been reported in the literature. But still, there are some studies where you may see a great difference, some where you don't see as much. And it really depends on the type of therapy that's involved. Sure. And so we're doing what's called intensive periodontal therapy, really trying to completely resolve the condition. Whereas in other studies that have been done by the NIH, they have done some therapy, but not complete resolution of the disease process. So it's very difficult to tell what the impact is. So I think we're trying to get at that causation piece.
Rob, your take on this?
Yeah, I would stress three things for this audience. First, this is all about systems science, so systems biology. Everything's related to everything else. We're learning about that. And so sorting out causation and correlation is difficult. And often there's going to be a mix of correlation and causation. Maria mixed the common risk factors, which certainly account for a lot of these associations. But remember that the common chronic diseases, cancer, heart disease, diabetes, are all linked with a set of common risk factors, and we have to chip away at each risk factor. This is one of them. The second key point is, what kind of evidence do we really need in order to be sure? And I think the study that we're embarking on will be an important step, but we're looking at intermediate biomarkers in the study, things we can measure in the blood and the physical exam. Ultimately, and this gets back to the study that Duke and UNC proposed to the NIH 20 years ago, ultimately, I'd love to see big randomized trials that get definitive answers about things like how long we live and our functional status. That's going to be a building block that we'll have to develop over time. And if our study is positive, as Maria said, that is that the full works is the key, then that would be a very important thing to know and to be sure about, because the resources to apply the full works to everybody, half the American population, adult population, would be a pretty big set of resources. So we want to be sure about that. And then finally, I would just make the point that when we look at healthcare resources in general, there's a dilemma that we're facing in the study that comes up over and over. Most of my career, I've been dealing with evidence, whether it was FDA commissioner or a researcher funded to do research. When we look at it, you'd say now anybody with gum disease ought to have it treated, right? But a minority of people in the United States who have gum disease, even though they have it, much less are having it treated. And so people will say, well, it ought to be treated. Why do you need to study it more? Well, the answer is we need definitive information about what the effective treatment is and what its ultimate impact on health is, because we have to fit it in with all the other things. And I think we're learning a lesson right now with COVID as a good example, that we don't have enough of the right kinds of clinicians for the problems that really need to be treated. And we've got to focus on fixing this problem. It's having a big impact on health outcomes in the U.S.
Yeah, and it also suggests, Rob, it ties right back to what you were saying several minutes ago, that our dental care should be part of our overall health care. That data, that information should be shared back and forth if they're going to be this tightly correlated. So how do we get there? What would it take to get that as part of this research and reform that we'd like to come out of it?
Well, I think, the relatively easy part now is the part that used to be the hardest, the technology part of it. That is, we can now link electronic health records. I mean, to a researcher like me and an intensivist, I ran intensive care units for a living. The beauty of dental data, you got a set of teeth, everything is demarcated. It's perfect for an electronic record. It can easily be interdigitated with your other health records if we choose to do that. The big issues, I think, are really on the human side. We have professional organizations that protect our current status quo. I'm not picking on dentists here. Medicine has the same issues. We also have to face what I brought up before, which I think is a really big issue. And let me just give an analogy for diabetes. If we say, how many endocrinologists are there in the United States? The answer is, I think it's somewhere around 20,000. How many people have diabetes in the United States? Tens of millions. There is no way on earth that everyone with diabetes is going to see the best specialist for their care. And I think what we're going to find, if this research works out the way I think it will, given all the previous research, we don't have the right number and distribution of dentists. And I'll particularly pick on, this study is in North Carolina, UNC, Duke, the area, very rural state, although they're, big cities in North Carolina too. Rural America, the distribution of specialists and people to provide the kind of expert care that you need is lacking. And you can see it now in this dramatic decline in life expectancy that we're seeing in rural America. So I would just see dentistry as one component of many other areas that mostly relate to chronic disease over time, where we really need to retool our healthcare system and our workforce to deliver more of what's needed on-prem. Go to people where they are. And, while the elegance of the high-tech biomedical science that we all love is really important and a forte of the U.S., this part of delivering what people need where they are is our real weak spot. And I hope those who are supporting research will get behind research to make the healthcare system better.
Rob, your company, Verily, talks about preventive care and the importance of preventive care as one of its cornerstones, right? And the need for better information and to serve, among others, vulnerable populations. Health disparities is a huge problem, and we're looking at that even more now than we have in the past because we're trying to reckon with a lot of disparities in our society. Marie and Rob, how is the research that you're doing specifically, if it is, looking at vulnerable populations? Are there particular things with respect to those populations and this issue of oral health and overall health that are of particular interest and concern to you? Maria, why don't you start us off?
Well, some of it has to do with access to care, and that's why this Medicare initiative is there. A lot of older people may not have access, and as we said, 55 and older is where you really start to see a significant number of people who suffer from it. A lot of people don't have dental insurance. Even in Medicaid, usually children are covered, not adults. And periodontal disease is more common in adults. But yet the insurance companies have really picked up on this, Frank. They have looked within their own databases. I think, Rob mentioned how dentistry and medicine is not connected. But there are some insurance companies like Aetna and others that have both medical and dental. And when they begin to mine their databases, they find that when you treat the dental conditions, the medical costs come down. And particularly, they see significant decreases in people with diabetes, people with stroke and with cardiovascular disease, women with adverse pregnancy issues. And they see decreases in hospitalizations in people who get their dental care. So that type of data is fueling this introduction within Medicare of this bill to also include oral care within Medicare, because the cost savings would be enormous. And so a lot of insurance companies have already started to look at this.
Rob, how is the study trying to, or will be able, how will the study help us sort out particular risks to vulnerable populations and responses?
Well, Frank, you're a professional communicator, and let me just say, half of my job is on the Verily side of the Alphabet family, and half is on the Google side, where I'm a senior advisor and help with many things. And one of them that we're working on very hard, as you know, is this issue of communication, particularly over the internet. Let me start just by saying the baseline study itself has been one of community involvement from the beginning. We got volunteers and we carefully recruited into the study, so we have a representative sample of people from all social, economic categories involved in the study, and we've been working closely with them so they understand what we're trying to do. Still, it's going to be interesting when we give people these free dental exams, and many of them find out for the first time that they've got gum disease that they didn't know they had. I would imagine the reaction to that's going to be quite different depending on one's life circumstances. And together with Colgate and the UNC Dental School, we have a set of questionnaires and ways of assessing how people are doing as they absorb this news and move into the intervention. So I think we'll learn a lot there. But just a word about what I'm learning as I work with Google. It's not a surprise to anyone that misinformation on the internet is a big deal right now. People are getting all sorts of good and bad information. We want to make the good information as good as it can be. And one thing I'll stress, particularly for this audience, is, when you look at YouTube, I had no idea. I'm getting ready to turn 70 this month. I had no idea there's a whole generation that mostly looks at videos, doesn't spend a whole lot of time reading. And so when you look at YouTube videos, if you said, let's take the information, which is not what you would necessarily want people to see, it's generally presented in very appealing, attractive ways. And if you said, let's take the body of information or the corpus that's reliable, high quality information, it's generally pretty boring. And so we've been working now to identify the reliable sources, the kinds of people you would want speaking to the public. And we're going to work with them to improve the likability of their content, because it doesn't matter how good your information is. If you're not saying it in a way that people can relate to it, you're wasting your time. And
That's exactly.
this is such a
exactly
bigger
right.
problem than I had understood before. Just to give you an idea of the extent of video watching, you might want to guess how many COVID-related videos have been downloaded from YouTube since the start of the pandemic. Well, the answer is 500 billion. 500
billion with a B?
With a B. Just try to absorb that. That's showing you the appetite of the public to get information. And those of us who are experts need to work really hard at translating our expertise into words and language and pictures that people can understand.
There's so much going on here, and your study is so important. Let me ask you both this. If the research indicates links between periodontal disease and systemic health, and some of these things that we've been talking about really are demonstrated through the research, where do we go from there? What are the implications about that? How does that drive policy? What does it mean for healthcare providers and consumers? Big picture stuff. Rob, you go first.
Well, I'm 100% sure we're going to find links. And so the question is, do we find causal links to a specific treatment that works? And what I would hope is that the NIH will get behind this if that's what we find, and fund larger studies that have a larger impact on society. Because if there's one thing I've learned dealing with heart disease my whole career, one study alone doesn't tell the story and doesn't sway everyone. You need massive amount of information to sway to the right thing. And as we generate the evidence, I would hope we will then put into place systems that deliver the care that matches the evidence that we've generated.
Maria?
Yeah, I agree with Rob. And I think we have done a number of studies, and this would confirm some and others. You know, obviously it is about the level of treatment. And as I said, this is intensive treatment, intensive periodontal therapy, non-surgical therapy, and very intensive home care. So we're using, as Rob mentioned, you know, this world is very connected. So we're using connected technologies to help inform people when they're doing a good job at home, managing, you know, the disease and helping the practitioner. And we can measure that now, and we can help people through our connected technologies as well as with products that really help to maintain things that are being done within the dental practice. So it's really a combination. Treating periodontal disease requires both the patient interaction and for them to be empowered to help, and for the practitioner to do their job. And I think also, you know, another thing that's really important that Rob mentioned is having our electronic health records integrated. And certainly there are some now that are becoming integrated with medical, because that has been a barrier for many years. And I think that will help to move all of this forward. And then, of course, you need the reimbursement and issues to be managed for prevention, for therapy, etc. And so we're all working on that. But I think that it truly is important that people manage their oral health.
Frank, let me just say, you know, I just got to say, for this audience especially, it's almost like, you know, this is an extreme example of the fragmentation of the U.S. healthcare system. And it's almost like, as a country, we invent and develop technologies. The rest of the world figures out how to use them. And we can't seem to get our act together. And this is just one really obvious example. The dentist and the doctors, we got to get our act together.
Well, Rob and Maria, thank you both for all the work you're doing, for the insight and your observations in this conversation. It's so important, and good luck with the study. Thanks again.
Thank you, Frank, and thanks, Rob. I look forward to the completion of the study.
Thanks, Maria. We're going to have a lot of fun and hopefully make a really good contribution here.